Community resources. A very lengthy list of nonprofit toll-free numbers that the client can call for information about key topics related to these two disorders. Mental health, substance abuse, parenting skills, physical health problems, HIV risk, domestic violence, and so on. And the idea there too is to empower them to take a consumer approach that they can seek out services and seek out information that may help their care. Recovery thinking, essentially cognitive therapy but applied to this dual diagnosis. What are thoughts associated with PTSD and with substance abuse? And in contrast, what are recovery thoughts? What would be a different way of thinking about things? And helping them learn to train their mind to go to a reframing, to rethink situations in a healthier way. Compassion, how to take a view of understanding their current situation in light of what they've lived through. And too often with these clients, they have not been given that perspective. Helping them learn that substance use, of course, is always a choice and that they are the ones picking up the substance. But nonetheless, even though there are no excuses, there are explanations for it. There are reasons why substance abuse is so common in people who have been traumatized.
What I took out of the treatment, compassion, kindness. Those things were very short in my life for a long time. You have a certain amount of self-loathing, shame, and I didn't know how to get rid of it. Kindness and compassion and understanding. Those things are pretty powerful. It helped me change.
Creating meaning. It's been found that people who can create positive meanings may have quicker recovery from PTSD, and helping them learn to come up with themes or beliefs, ideas that may help inspire them to keep moving forward in their recovery. Commitment, how to make and keep a promise. And often these clients will say that people have broken promises to them throughout their lives and they never learned how do you follow through on things? How do you do things even though you don't feel like it? And so there's some specific behavioral skills and also attention to the emotions that they may need to attend to in order to just follow through. And if you remember, at the end of every session, they make a commitment of one thing they'll do before the next session. Whatever it might be, however small it might be, the idea is to continually reinforce moving forward in their lives.
When they do the homework, they really seem to get a lot out of it. They realize that their treatment is moving along faster than if they don't do the homework, but that's certainly one of the things that I hear from them is, oh, I don't have time to do the homework, and I don't have time to practice the skills outside of the session. That's certainly been a focus of my work with all the clients, is to encourage them to practice the skills outside the session, not just in the hour that we meet during the week, that it's very important that they practice that.
Honesty. One of the topics that clients say may be one of the most important topics to them. How and when to open up, both around the substance abuse and the trauma. Coping with triggers, standard relapse prevention, basically in the words of AA, change people, places, and things. What to do when they're triggered, how to avoid triggers, and so on. Healing from anger, the idea that anger often is inevitable for many of these clients. Anyone would feel angry if they lived through what these clients have lived through. But that anger can be used either constructively or destructively. Destructive anger is acting out against self or others, self-harm, self-mutilation, and so on. Constructive anger is hearing the anger as a signal that they can listen to and respond to. If they keep getting angry at someone, maybe that's not a relationship that they should be in at this point. Or maybe they need to talk to the person and negotiate something in that relationship. So anger itself isn't a problem, it's more how do they deal with it and how can they use it constructively. Discovery, a concept in cognitive therapy of identifying a belief that they can go out into the world and test. And for many of these clients, their thinking has become rigid. They think in old patterns. It's hard to get unstuck. And so the idea here is identify a belief that is testable. For example, if I went to AA, I would hate it. If I apply for a job, I won't get it, and so on. And then have them go out, find out what happens, and come back and report on it. Now, sometimes they'll find out bad news. It didn't go well, and they were right in their prediction. But the idea is that all knowledge is power, and that they can use that information. If they didn't get the job, they can do job counseling or get some assistance in how to apply for a job, and so forth. Self-nurturing. How to have pleasure in healthy ways. Substances often were a way to feel good that ultimately ended up being very destructive in their lives. Pain and pleasure may have become very distorted concepts for these clients. Particularly if sexual abuse was there early on, they may have confusion or fear about pleasure in their lives. Some of them will say they haven't experienced pleasure in years. And the idea is help them identify ways to feel pleasure in healthy ways. It might be taking a walk, taking a bath, playing with a pet, and so on. Getting others to support your recovery. Basically trying to involve safe family members or friends who can come in and get some education about PTSD and substance abuse. One thing many clients say is that it's very painful to them that no one seems to understand about the trauma, that family members may view it as an excuse. That's just an excuse for not working on addiction, and so on. And the idea here is to bring in the family member, give that family member some resources as well, whether Al-Anon, referral to couples counseling or family therapy, whatever might work for that particular client and their family. Many clients have no one to bring in, and then we focus basically on how can you get people in your life who will be healthy for you. Respecting your time, how to schedule your day so that there's some amount of time that's productive, that's planned. Both with substance abuse and mental illness, one thing we know is that the client who has no structure, no activities during the day, tends to get worse and more symptomatic. So giving them literally a schedule blank and then having them fill it out, looking at how they've spent time in the past week and how they might spend time in the week up ahead, future focused. And the idea is that time is the ultimate resource. They may have lost time in the past due to these disorders, but there's a lot they can do now to make their future better. And looking at issues like, do they spend a balance between time alone and time with other people, recovery activities and other activities, structured time and leisure time, and so on. Healthy relationships. What are the signs and beliefs that go along with healthy relationships? And for many clients, just discussing these ideas out loud can help them learn to identify some long-held beliefs they may have about what they tolerate in relationships that maybe they shouldn't have to tolerate, or how they maybe could get into relationships that might be healthier for them.
And when it would get physical and if you hit me or something, I didn't, after it happened like a few times, and almost to me, because I was still drinking, that it just seemed like part of the life, like that's just the way it is. It's almost like I knew better, but I felt like I didn't know any better. It was just what was supposed to happen. And it didn't really bother me. It was just like putting on my shoes in the morning. It was just what I did.
Integrating the split self. Really more than most other Axis I disorders, there's the concept of splitting in both PTSD and substance abuse. In PTSD, clients will often say there's some side of the self that they're trying to push away. The young side, the angry side, the weak side, the vulnerable side. When I was weak, that's when I would get hurt, so I've learned never to show weakness. In very severe cases, you have what's called dissociative identity disorder, where the client may have literally alters or different personalities within the self who may or may not even know each other. Different genders, different ages, different personalities. Those clients will need very expert, long-term, and focused help with that. But even in clients who don't have that full-blown dissociative identity disorder, you often see these splits within people with PTSD. In substance abuse, what's sometimes called the Jekyll and Hyde personality. I'm with the program, I want to get clean and sober, and then suddenly they flip into a different state of mind. I don't know, I was walking past the bar and I just found myself in there getting a drink. And the nature of these splits, until they're recognized and integrated, often is unconscious, and they may flip from one state to the other without actually recognizing that it's happening. And a lot of dangerous behavior tends to occur when these flips of state of mind happen. So helping the client learn that ultimately integration is the goal, owning all sides of the self. Red and green flags, what are the signs that they're getting worse or spiraling downward, and the signs of getting better and spiraling upward? And clients identify here from a checklist a variety of behaviors, attitudes, and so on that may sort of help to signal them for when they're going downhill. When I get cynical, when I get too angry, when I stop attending AA meetings, when I stop showing up for treatment, when I isolate, and so forth. And in this topic, they're also taught to create a safety plan. What will they do at mild, moderate, and severe levels of danger? And hopefully sharing this plan with other treaters and with family members so everyone can help the client identify if they're in a downward spiral and hopefully shore them up, get them the support they need, and move back to a better place. The Life Choices game, a review topic, basically designed to be random like life. They pick a slip of paper from a little box or a hat, and it has on it a very difficult life event. And the idea is to pull out the slip of paper, read the situation out loud, and here's their test. How would they cope with this event without any substance use or any other unsafe behavior? The slip of paper might say, you just lost your job. You found out your partner is cheating on you. You found out that your daughter has been abused, and so on. And the client has learned, hopefully by this point, that no matter what happens in life, there's a way to cope safely without substances or any other unsafe behavior. Finally, termination, saying goodbye and planning aftercare. And typically that process starts occurring way earlier in the treatment. It can take a long time to do that work, but nonetheless, ultimately terminating eventually with the treatment. And throughout the treatment, strong attention to language, words like safety, respect, honor, and healing. Simple language, trying not to use jargon or scientific sounding terms, trying to connect with them emotionally at the level of language. Finally, a checkout. Name one thing you got out of today's session and any problems with the session. That comes from educational research where it was found that students in school actually learn more if the student identifies one thing they learned in that classroom session. And the idea here is this also helps the clinician get some feedback. What made a difference to the client? And it may or may not relate to the topic that was covered. Any problems with the session is to help the client learn to express if they're having a negative reaction. The goal is to try to retain the client in treatment. And some of these clients will be over solicitous of authority figures. And so the idea is always ask them what they don't like. It doesn't have to be addressed right now. One can just hear the feedback, maybe make a plan to discuss it after the session, or just say, thank you for being honest about that. But basically just listening to it. What's your new commitment? Picking something they can do between now and the next session to move forward in their lives. And they're committing to themselves, to you as the clinician, and to the group if it's a group treatment. The commitment does not have to be written. Many of these clients do not like written assignments. They didn't do well in school. The idea is really just to pick something, whether it's making an appointment with a healthcare provider, asking a boyfriend not to offer them substances, whatever it might be. The treatment philosophy overall goes back to a set of core principles. Safety as the priority, that is the thing to focus the client on. Integrated treatment of both PTSD and substance abuse. The idea is that PTSD and substance abuse can be treated together from the very start of treatment. The client doesn't need to be stabilized before working on PTSD if the focus is present-focused, coping skills, psychoeducation, and so on.
The integrated approach was really fundamental for them in being able to connect the substance use around the symptoms of PTSD, such as an intrusive thought or being triggered by a scent, a place, an idea, dreams, sleep disturbances, those kinds of things. In many cases led those clients to use substances. So for them, when they made that integration, not only within the group, but within themselves, when they realized and connected that piece, in some cases, one patient A young 25-year-old white male said, the light bulb just went off in a group one day. And for most of us, it was a moment of clarity. For him, the light bulb had finally gone off.
A focus on ideals. Throughout the treatment, the topics are designed to help inspire the client and to feel motivated. So things like compassion, honesty, taking good care of yourself, respecting your time, all of them are framed as some sort of positive ideal to strive for. Many clients will say that even more than the physical incidents of trauma, it was losing sense of faith in other people or losing a sense that the future could be good. Content that's cognitive, behavioral, interpersonal, and case management. Structure and flexibility. The sessions are structured, there are handouts, there's a check-in, there's a check-out. The idea is to help them know what to expect. And clients will sometimes say it helps them feel contained or safe to know what's going to happen in every session. However, there's also a lot of room for flexibility. The idea is to go as a clinician where you need to go with the client, to let the client decide also where do they need to go within a topic.
We have taken a given topic and we have extended it across 2 or even 3 sessions depending upon the topic.
Simple human language and very strong attention to therapist processes. Countertransference. It's often said that the more intense the clients, the more intense the clinician's response to them. Self-care. In working with very impaired clients, it's very important for the clinician to learn to take care of themselves emotionally, to be able to leave the work when they leave the office.
The process within the clinician is really a central theme, and it was something that we spent a significant amount of time around. Issues of countertransference, issues of just responsivity to the materials from the clinician's perspective, and the process of going through this material. In many cases, we found clinicians responded on a number of levels, both emotionally, personally, certainly professionally and clinically. So an essential piece of a clinician adapting and learning this model is self-care.
And attention to a process often termed secondary traumatization. That the clinician themselves may experience some symptoms of trauma when they're repeatedly exposed to clients' very difficult traumatic histories. And so throughout the treatment, the idea is for the clinician to really focus on themselves as well, and also to use the safe coping skills in their own lives, that the people who best teach it are the ones who are doing it in their lives. It's often said that healing from PTSD and substance use disorder actually requires more than just decreasing symptoms or learning to function, but that at some level it's a transformation of identity, from victim to survivor, from silence to finding one's voice, from powerlessness to a sense of control, from isolation to connection.
My whole past 13 years is just a cloud to me. I don't know who I am. I don't know what I like. I don't know what I don't like. I don't even know my kids. And I've been in treatment and they're with me, and it's like I'm just starting life over. Like I'm just learning about myself. I'm learning about my kids. I'm understanding why I was drinking. I'm understanding my character defects. I'm understanding how to cope with it. It's like I'm starting my life over.
Some examples of the empirical work, the scientific studies on seeking safety. A study by Hien and colleagues published in 2004 on low-income urban women. This was a randomized controlled trial, outpatient, 3 months of treatment. Therapy was run twice a week in individual format, each session being an hour long. And clients were severe in both PTSD and substance use disorder. They had lived with the disorders for many years, typically quite severe and chronic. Seeking safety and relapse prevention were the 2 manual-based treatments that were used, and then there was a third arm of the study, treatment as usual, where clients would just get whatever treatments they were normally getting. And that was a non-randomized control in the design. And both seeking safety and relapse prevention showed greater reduction than treatment as usual in substance use frequency and severity, PTSD symptoms, and psychiatric symptoms, with the results sustained at 6-month follow-up. Women in Prison, a study by Karen Zlotnick and colleagues, published in 2003. 17 women with current PTSD and substance use disorder, primarily substance dependence, the more severe form of substance use disorder. It was a group version of Seeking Safety, conducted an hour and a half twice per week for 3 months. And it was voluntary in the prison setting. Clients could choose to come or not come. They attended an average of 83% of available sessions, high client satisfaction, and 53%, which is 9 of the women, no longer met criteria for PTSD at the end of the 3-month treatment, and 46% no longer met criteria for PTSD at the 3-month follow-up. Substance use could not be assessed while they were in prison because it's a crime, so it couldn't be asked. But at 6 weeks post-release, 70% did not meet criteria for substance use disorder. Criminal justice populations often have extremely high rates of both PTSD and substance abuse.
Trauma and addiction are really big issues for women in prison. A lot of the reasons that they're incarcerated are things like prostitution and things like that, which, you know, there's a lot of trauma involved in that, and they tell stories about getting jumped and getting robbed and getting beat up, and so just in the course of the things that they do to support their habit, and the things that eventually land them in prison, have a lot of trauma attached to them, and they don't always identify that as trauma at first. Sometimes they just see it as it goes with the territory. So that's another way that I think Seeking Safety has been great in that environment, is that it brings awareness to the women of, oh, so this is why I feel the way I feel, and helps them make sense of some of the things that drive their substance abuse.
Outpatient women, a study published in 1998. Group treatment, outpatient, 25 sessions in 3 months. It was run twice a week, each session being an hour and a half. And results are reported on the 17 who completed 6 or more sessions, which was 63% of the 27 women who initially enrolled in the study. There was no control condition because it was a pilot study. Clients improved significantly in alcohol and drug composites on the Addiction Severity Index, one of the most widely used measures of addiction symptoms. They improved in trauma-related symptoms, depression, suicide thoughts and risk, cognitions, knowledge, family and social functioning, and problem solving. They worsened in somatic symptoms. Hard to know exactly what that is, but it could just be sometimes somatization is very common in these clients, and when they're no longer using substances, they may be more aware of physical symptoms, or it could be related to early withdrawal from substances. They attended 67% of available sessions and reported high treatment satisfaction. Completers were more impaired than dropouts. This is a finding you sometimes see in studies, that the people who are more severe stayed in. In terms of implementing Seeking Safety, there are several principles that can help to really make it a treatment that can work for clients. First of all, trying to attend in every session, if possible, to both discussing the skill and rehearsing the skill. It's very natural, both for clients and clinicians, to discuss a skill. For example, the topic asking for help. Clients can easily talk about that, how maybe they had no one to get help from, how it's hard for them to ask for help, how they don't know how to ask for help, and so on. At some point in the session, the goal is to get them to rehearse it. What would it actually sound like out loud? Can we do a role play? Can you say it in words? In terms of rehearsing the skills, there are a variety of ways to go about it. For the interpersonal topics, it will often take the form of a role play. What does it sound like? I'll play the other person. You play yourself. How might you say it? Cognitive topics may involve a think aloud. For example, the client who's working on the topic compassion. What does it sound like in your mind when you use harsh self-talk? I'm a loser. I don't seem to do anything right. I don't think I'm ever really going to get better. I don't know why other people can and I can't. Okay, now can you try compassionate self-talk? What might that sound like? And have them literally think out loud. There are reasons why life has been hard for me. There are reasons why I'm in the place I'm in, and other people may not have experienced what I've experienced. I think with work, I may be able to make things better in my life. Good. So you get them to do a think aloud and really listen to how they talk to themselves. Behavioral topics, you'll often do a walkthrough. For example, the topic, taking good care of yourself. Maybe the client will commit to making a dentist appointment. And you might want to ask them, do you have the name of a dentist? Do you have insurance or other ways to pay for it? Do you have a way to get there? Do you have childcare if you need it? Are you afraid of the dentist and need someone to go with you? Literally walking them through all the steps they may need to take in order to make that happen. John Dewey, the famous American educator, had a wonderful phrase, learn by doing, that it's by actually trying things out that the client can most deeply learn the skill. Also balancing the client issues with the coping skill. Clients walk into the room with a myriad of issues. They may have had a hard week, they may have had struggles of all kinds. And they're coming in, and at the check-in, they'll tell you about what's going on in their lives. You're walking in with a coping skill that may be new to them. And the idea is to connect the two. For example, if your topic is asking for help, and the client said that they used this week, for example, used heroin or cocaine, you might say, did you try reaching out for help before you used or after you used? Did you tell anyone? If your topic was recovery thinking, you might say, what did you say to yourself before you were using? What were the thoughts in your mind before you picked up the cocaine? So the same event, the client has picked up a substance that week, but you may approach it in a different way depending on the topic you're trying to teach them.
Particularly with the HIV positive patients, certainly that group took on a central focus of trauma and substance use disorders, which is intended by the model, but it took a special emphasis around medical case management issues, physical health issues, and really took a central focus on safe behavior to not only ensure the patient was being safe with their own bodies and really taking good care, good self-care, which is a central theme of seeking safety, but also in reducing unsafe behavior within the community. So we really took a central focus on how we could utilize the strength of the Seeking Safety model, but within that specific context of those unsafe behaviors of HIV that persons with HIV struggle with on a daily basis.
If there's too much focus on the client issues, it can get all over the map. The session may feel like you're not really making progress and they're just venting or just talking at great length without actually working on a skill. If, on the other hand, you focus too much on the coping skill, it can feel like school, as if you're almost not attending enough to what the client is bringing in the room. And so the idea is to keep moving in and out of the client issues and the coping skill. A key question throughout the treatment, how did you try